What's up, Ninja Nerds? In this video today, we're going to be talking about hyperlipidemia. This is a part of our clinical medicine section. If you guys like it, helps you, please support us. One of the ways that you can do this is by hitting that like button. You could also comment down in the comment section if you'd like, and hit that subscribe button if you really like our video content. Also, I really urge you guys, go down the description box below. There's a link to our website. We have a lot of great things that we offer there that we don't have on our YouTube, such as notes, illustrations, questions. We're developing actual exam prep programs for those of you taking your exams, your board exams. Also, we got some Ninja Nerd kind of swagoo that you guys could check out. So please take some time and go look at that if you'd like. Hyperlipidemia. What is the problem with this? Well, you can define this a lot of different ways, right? A lot of the times, hyperlipidemia is the most common terminology that we utilize, and oftentimes it really consists of an abnormality within some of the lipoproteins or lipid molecules within our bloodstream. I think what's really important when we're talking about these is to understand the particles that are truly involved in the disease processes that we see with hyperlipidemia. So one of these is a really problematic molecule here, and this is called LDL. So LDL is one of these molecules that if you have really, really high amounts of LDL, it really can be associated with a lot of atherosclerotic plaques, which we'll talk about as the complications of hyperlipidemia. So this is not a very good one to have high amounts of. That's one way that we could define hyperlipidemia or dyslipidemia. Another molecule that is also super important in kind of the process of lipid transport and a lot of the things that are going on there is a molecule called HDL. Now, a lot of people neglect HDL, but HDL is super important because it's one of those guys that's primarily proteins and phospholipids, and it kind of helps to scavenge and pull some of the cholesterol and fat away from the peripheral tissues, such as the blood vessels, which helps to reduce a lot of the atherosclerosis. So if a patient has very, very low HDL levels, this also is a problematic issue. However, when you hear the term hyper, you don't commonly associate that with a low level of a molecule. You associate it with the high levels of a particular molecule. But just remember in your head that in hyperlipidemia, it can be high LDL or low HDL. Sometimes we use this terminology here where someone has high LDL and low HDL, we use the terminology dyslipidemia because there's an abnormal process or abnormality within the actual lipid particles. Last one here is going to be you got this glycerol with the fatty acids hanging off of it. What's this bad boy? This is the triglycerides. These are also problematic. They don't really carry that same exact intense risk of atherosclerosis, but they do carry a pretty high risk of tissue deposition, particularly the liver, the pancreas, and then cause a lot of havoc there as well. So when you think about hyperlipidemia, what you're really thinking about is patients who have very high levels of LDL, which carries lots of cholesterol, deposit that in the blood vessels, low levels of HDL, they don't remove some of that plaque from the blood vessel wall, or high triglycerides, a lot of soft tissue and visceral organ deposition. All right, cool. Question then arises, okay, how do I get lots of LDL in my bloodstream? How do I get lots of triglycerides in my bloodstream that lead to these disease processes? Well, one is it unfortunately could be inherited. Not the best ideal thing, but inherited hyperlipidemias you want to think about in the young kind of patients, or patients who are like getting their blood work done and you just keep noticing that their blood levels, their actual cholesterol levels, their LDL, their triglycerides are massively elevated despite therapeutic measures, okay? So first one is we have type 1. In type 1, the primary disease process here is that you have a defective what's called lipoprotein lipase. This is an enzyme, and we're not going to go into the crazy depths of this because we covered in our actual pathology lecture here. We're going to be kind of basic here. But there's a defect within the LPL, the lipoprotein lipase. We'll put a down arrow here. What it's supposed to do is take molecules called chylomicrons. And when it takes these chylomicrons, it can do this for chylomicrons and sometimes also for VLDL particles. It's supposed to help in ripping some of the triglycerides from the chylomicrons and having them being taken up because it breaks down the triglycerides into free fatty acids. So that's what it's supposed to do. But in this process, there's a defect within this LPL and it doesn't allow for that process to occur. So what does chylomicrons carry a lot of? Triglycerides. So what happens is that these patients develop crazy high levels of chylomicrons, like insanely high levels. And chylomicrons are what? They are rich in triglycerides. And so what these patients develop is crazy, crazy, crazy high triglyceride levels. Because you're supposed to, in these patients, take the chylomicrons, which contains the triglycerides, rip them apart into free fatty acids, and the free fatty acids are taken up by the adipose tissue in the muscle, but it doesn't occur here. That's one potential way that you can develop hyperlipidemia. So again, type 1 is one of those disorders. Now, type 1, usually what happens is there is a mutation. And the easy way to remember this is that it goes recessive, dominant, recessive, dominant. Okay? So this would be an autosomal recessive disorder that leads to a lipoprotein lipase mutation, altering chylomicrons from being degraded. They end up accumulating and increase your triglycerides. Boom, hyperlipidemia. Type 2, well, we already said autosomal recessive, so this has to be autosomal dominant. In this disorder, there is a defect in the LDL receptor, all right? So the LDL receptor is the problem here. So we're gonna put that there is some type of defect here or decreased activity of this receptor. What this receptor is supposed to do is take LDL particles and do what? Bind onto them and bring them into the liver to use the cholesterol from the LDL, make particular types of molecules. But it's not going to. And because of that, what happens as a result is if this process does not occur, now what results is the LDL stays elevated within the bloodstream. And if LDL remains elevated within the bloodstream, it carries tons and tons and tons of cholesterol with it. So what happens to the patient's cholesterol levels? They really go through the roof. And so what you'll notice is that these patients will have insanely high total cholesterol levels because they have insanely high LDL levels. So type 1, high triglycerides, type 2, high LDL, leading to an elevated total cholesterol. Autosomal recessive, autosomal dominant. All right, type 3 and 4. All right, for this one, it's also a mutation, recessive, dominant, recessive, dominant. Let's write these out. So for this one, it will be autosomal recessive, autosomal dominant. Nice way to remember, right? Now, when we talk about these, in type 3, this one's a weird one. So in type 3, there is a defect within what's called the ApoE protein. So there's a protein here you see on these guys. So this is called the ApoE protein. This apo here, we'll put like a little hyphen here to really kind of denote that this is a specific type of apoprotein. So ApoE is defective. So what we're going to do is we're going to put like an X there. All right. What ApoE is supposed to do is it's supposed to take particles like what? Great that you asked that. It's supposed to take things like chylomicron remnants and VLDLs and uptake them. But that will not happen. So what ends up happening is you have these things called VLDLs, which carry lots of triglycerides and cholesterol, and chylomicron remnants, which carry lots of cholesterol, but really lots of triglycerides. Because you can't take these bad boys in, guess what ends up happening? You end up accumulating things like these. And if you have lots of VLDL and lots of, we're going to abbreviate these chylomicrons, we're going to put chylo here, remnants, these carry lots of cholesterol and lots of triglycerides. And so what happens is these patients develop very high triglyceride levels and very elevated cholesterol levels. And that's what you'll see as a result of this, is they'll have lots of these VLDLs and chylomicron remnants, and subsequently lots of triglycerides and lots of cholesterol. So if I said massively increased triglycerides, you'd say type 1. If I said massively increased LDL, you'd say type 2. If I said increased chylomicron remnants and VLDL, which causes both cholesterol and triglycerides to go up, you'd say type 3. That is the difference here with this one. Lipoprotein lipase mutation, LDL receptor mutation, ApoE mutation. For the last one here, this is a very interesting one. your liver is supposed to produce this molecule called VLDL, right? So it's supposed to make a molecule called VLDL, which carries lots of triglycerides. Chylomicrons and VLDLs carry lots of triglycerides. LDL particles carry tons of cholesterol. So what happens is, in this particular scenario, there is a increased synthesis. So we're going to write here a increased hepatic synthesis of VLDL for some particular reason. When that occurs, VLDLs are in massive amounts, and what they will do is they will increase the triglycerides pretty substantially. So now you're kind of in a situation where you're like, okay, well, which one, how would I differentiate these? Again, autosomal dominant for type 4 has massive hypertriglyceridemia. Type 1, which is an autosomal recessive, has massive hypertriglyceridemia. One of the ways that they try to tip you off in the exams is when you look at the actual blood, when you take a sample of blood from these patients, if it says a creamy kind of like layer on the top of the blood sample, that's usually indicative of heavy amounts of chylomicrons, as compared to the increased VLDL causing triglycerides to be super high. This is how we would talk about the causes of hyperlipidemia when it's inherited. All right, so let's start talking about acquired hyperlipidemia. Now, within this is usually disease states or drugs that are causing this particular process. So first one, diabetes is a big one. What happens is you have this molecule, this enzyme here, which we already talked about, called lipoprotein lipase. Now, it does help with breaking down chylomicrons, but remember I told you there's another molecule that helps to break down the triglycerides. VLDLs, remember, VLDLs and chylomicrons are rich in triglycerides. So they have the ApoC2 protein to bind with LPL. Again, we'll talk about that more in the actual pathology lecture. But if we take this guy here, which is our VLDL, he should be naturally having triglycerides ripped away by the LPL, metabolized by adipose and muscle. But what happens is in patients who have diabetes, they have some type of problem with their insulin. Maybe it's insulin resistance, maybe it's a decrease in insulin because of an actual disease process. Whatever it may be, there is a decrease in the effectiveness of insulin. If there's a decrease in the effectiveness of insulin, what happens now is that this leads to the inhibition or the decrease in the activity of this enzyme. Can this enzyme now take and rip away the triglycerides and convert them into fatty acids? No. So what happens is as a result, VLDLs begin to accumulate. And VLDLs can easily convert into another molecule. So now you're going to end up with an increase in VLDL. And do you know VLDLs that have rich in triglycerides? But you know that VLDLs, a lot of them convert eventually into LDL. So you'll also see an increase in LDL. So totally, you could see an increase in triglycerides and an increase in cholesterol in this patient population who have diabetes. Boom, roasted. Hypothyroid related. In this scenario, when a patient has hypothyroidism, they have less of what's called T3 and T4. Now, T3 and T4 are interesting. When they're made by the thyroid, what happens is they're supposed to go to the liver. And when they go to the liver, they're supposed to maintain the expression of the LDL receptors. But that doesn't happen now if you don't have them. So the LDL receptors are now downregulated. If you don't express these LDL receptors, can you bind LDL? No. And so now this is supposed to bind here, but it doesn't happen. And if it doesn't happen, the LDL molecules will build up within the bloodstream. And if LDL builds up in the bloodstream, this will effectively increase the patient's cholesterol, precipitating hyperlipidemia. All right, we come into the last disease state here, which is called nephrotic syndrome. Now, nephrotic syndrome is a really cool mechanism here. There's a disease where the glomerular filtration barrier, particularly the podocytes, are damaged, and they're having a hard time being able to maintain the loss of protein. So these patients lose tons and tons of albumin in their urine. So we call that albuminuria. You can also see this in CKD. But what happens is, when you have all this albuminuria, as a result, you don't maintain as much albumin within the blood. And so the albumin within their bloodstream is low. Now, who is the organ that makes albumin? The liver. So what this does is this tells the liver, hey buddy, albumin's pretty low, start making proteins. But unfortunately, the liver doesn't really know the difference, and it starts making a bunch of different types of proteins. And unfortunately, some of those proteins that it decides to synthesize here is going to be VLDL and LDL. And these puppies will increase, and the patient can develop hypertriglyceridemia, hypercholesterolemia, and again, there is the disease process. There is some medications that are also involved here. The mechanism as to how they do it isn't completely known, but you have beta blockers, you have oral contraceptives, thiazide diuretics. Those also can trigger hyperlipidemia. All right, with that all being said, now we have to come to the point is, if a patient has hyperlipidemia, elevated LDL, elevated triglycerides, low HDL, what are the complications that can arise? All right, my friend, we have a patient who has hyperlipidemia. What are the complications that can arise? Well, the first one is atherosclerosis. By far, really big risk factor. Remember, atherosclerosis can be due to smoking, it can be due to advanced age, diabetes, it can also be due to cholesterol problems, and it can also be due to hypertension and family history, but cholesterol problems is a big one. And particularly, I'd say the most problematic one is going to be the LDL. Yes, triglycerides can contribute to this, but by far, it's going to be the super elevated LDL molecules. What's going to happen is that, and I would also go as far as to say low HDL. But for right now, we talked about all the disorders that lead to an increased LDL. Inherited, primarily type 2, right? And then we can see this really in all of the acquired types, right? Because of this, as the LDL goes pretty high, what's going to happen is this going to lead to atherosclerosis, these plaques that develop within the vessel walls. When atherosclerosis develops, it can develop in vessels of very vital organs, such as the heart. In the heart, if these plaques occur, they can cause ischemia to the myocardium, potentially something like coronary artery disease, and worst case scenario, it can cause infarction of the myocardium, such as a myocardial infarction. The other thing is it can cause a transient ischemia of the actual cerebrum. So we don't perfuse the brain vessels as well. And you can develop a TIA. Worst case scenario, these patients can develop CVA, a complete infarct or stroke. The last one here is you develop ischemia to the lower extremity. So this can develop something like peripheral artery disease. But if the peripheral artery disease continues to progress because you plaque up these vessels and narrow the actual blood flow, sometimes these patients can develop things like critical limb ischemia. Or if you cause a thrombosis of the plaque in these actual vessels, it may lead to an acute limb ischemia. So you can see how just having super elevated LDL or low HDL in patients, regardless of their cause, can lead to atherosclerosis over time, and the consequences downstream from that. Pancreatitis is heavily associated with high triglycerides. So when I talk high triglycerides, I'm talking crazy high. So I'm talking like you can definitely see this in patients with type 1 or type 4 inherited hyperlipidemia. And you can see this in really a lot of acquired hyperlipidemias, especially those with very, very poor diets. What happens here is it needs to generally be at least greater than or close to 1,000 milligrams per DL. When that triglycerides are that high, they can activate pancreatic enzymes and lead to pancreatitis. And obviously pancreatitis can lead to massive pancreatic inflammation, which you want to watch out for so many complications for, but epigastric pain and a patient who has massive hypertriglyceridemia, maybe with some associated nausea, vomiting, and other associated complications, definitely think about pancreatitis. All right, my friends. Now, the last situation here is steatosis. This is fat accumulation within the liver. And patients who have very, very high lipid levels. I'm talking super high LDL, super high triglyceride levels. What happens is this fat really deposits heavily within the liver. And when it deposits heavily into the liver, it leads to something which we call steatosis, which is just kind of like a fatty liver, if you will. What happens is this steatosis can activate inflammatory cells. These inflammatory cells will then come in and trigger inflammation of the steatotic liver. When you inflame a liver, now it's fat-laden and inflamed. This is called steatohepatitis. Now, the last particular scenario that can result, and this is why it's so important to get a hold of this, is that then you can start laying down fibrous tissue. And when you lay down fibrous tissue, this is irreversible loss of actual liver function. And this will start leading to a patient developing something like cirrhosis. This is super common in patients who have what's called non-alcoholic steatohepatitis or non-alcoholic fatty liver disease, where they have intense hyperlipidemia that can literally lead to cirrhosis. The last things that I want you guys to talk about, I don't have it here, but are going to be soft tissue deposition. So sometimes when your cholesterol is really high, your triglycerides are really high, these actual molecules can deposit into the tendons and lead to something called xanthomas. Another thing is it can deposit into the actual tissue on the medial side or the nasal side of the eyelids. We call that xanthelasma. And the last thing is sometimes a lot of triglycerides can deposit around the cornea and precipitate something called a corneal arcus. Given these findings, these are the biggest things that I want you guys to remember for hyperlipidemia. But now that we've talked about it, let's go over the actual diagnostic approach. So the next thing is, okay, we have a patient who comes in, maybe they have some xanthomas, some xanthelasma, maybe they have an underlying history of atherosclerotic cardiovascular disease, maybe they have some underlying steatosis that was found incidentally on an ultrasound or a CT scan, or they have pancreatitis for whatever reason. You have some things that are definitely cueing you in here, so you're going to go ahead and approach how to diagnose this and then subsequently how to treat. Well, the first thing that you have to be able to ask yourself when you're treating hyperlipidemia or trying to diagnose it, even in general, is are they going to require statin therapy? Statins are the primary therapy for hyperlipidemia, regardless of the type. And when you think about this, there's about 4 reasons why you would do this. One is, do they have clinical atherosclerotic cardiovascular disease? In other words, do they have evidence of CAD? Do they have angina? Have they had any evidence of MIs? Have they had a TIA? Have they had a stroke? Do they have peripheral artery disease, or had they have any events of acute limb ischemia or critical limb ischemia? If that is the case, or even do they have aortic aneurysms that were incidentally found? If that is the case, they need to be on statin therapy. It's super important. Is their LDL greater than 190? Because they're at super high risk for atherosclerotic cardiovascular disease. So that's, again, another indication. The third one is do they have diabetes? Diabetes is a huge risk factor for a lot of vascular diseases, but on top of that, when your age starts increasing to at least 40 to 75 and the LDL is greater than what we would want, especially 70, your risk of atherosclerosis and disease processes increase significantly. So these patients need statins. And lastly is the patient who's not a diabetic, but their atherosclerotic cardiovascular disease risk comes out to be greater than or equal to 7.5%. And the way that we determine that is we plug it into a calculator, and it looks at a lot of different risk factors. But the whole point is what's the 10-year risk of a patient developing a stroke or MI because of their hyperlipidemia or other risk factors. And this is going back to that SAD CHF thing. So this is the mnemonic to remember for atherosclerosis. Smoking is a big risk factor. Age is a big risk factor. Diabetes, high cholesterol, especially increased LDL, and even low HDL, which is important to remember, and hypertension and a family history of underlying vascular diseases. So if that is the case and you find that that risk is greater than or equal to 7.5%, okay, they have an indication for statin therapy. So if you've reached any one of these, then okay, what do we do? Well, first, you always want to initiate lifestyle modifications. It's always great to say, okay, is there any way that we can get you to work out a little bit, change your diet, see if we can improve that, and then recheck you? Okay, we can try that. Now, let's see if that improves with these kind of standard therapies, modifiable risk factors, if you will. You can change some of the things like your diet and exercise to improve diabetes and cholesterol. You can't change your family history and you can't change your age, but you can stop smoking as well. So these are things that you should always institute. But here's the big thing. In all of these, you're going to do this no matter what. But if you have any one of these, you'll do this, plus you will initiate high-intensity statin therapy. It has to be both of them if you have any of these right here. And usually the high-intensity statins, to keep it simple, is usually atorvastatin, 40 milligrams or 80 milligrams, or rosuvastatin, 20 milligrams or 40 milligrams. Anything for these, under these doses, or any other statin is not a high-intensity statin. That's really all you need to know. But if you meet the requirements for being on them, start them on these statins, and then ask yourself the question, okay, if they're on these statins, what are the potential complications? And the potential complications is based upon this statement here. One is rhabdomyolysis, and the other one is hepatitis. And so you should actually obtain a baseline, see what they're at before you start their statin therapy. And then if they become symptomatic, and only then, if they show features of jaundice or right upper quadrant pain suggesting hepatitis, or rhabdomyolysis, they suggest muscle pain and maybe some dark urine, then you will recheck them and see if they're elevated. If they are, okay, I should probably discontinue the statin for a little bit. And then when I restart them, start them on a lower dose. Now, if you have done this, that's great. But the next thing is, okay, let's come back to here and say, all right, we've tried the statin therapy. They've been maxed on it. They're still not getting their LDL down and it's not at goal. What do? Add on another agent. And the best agent to add on here is ezetimibe. All right, and we'll talk about what that does a little bit later. It's a cholesterol absorption inhibitor. If they do not meet their goal with that, then what do? Then you add on one of two drugs. One is a bile acid sequestrant, or the other one, which is really, really good, is a PCSK9 inhibitor. They're just expensive as all heck. But this is the steps that I want you to remember to treat hyperlipidemia in a systematic way. The next thing is, okay, we have a lot of medications that are out there that are being utilized to treat hyperlipidemia. Can we go through them, Zach? No problem. First thing is statins. These are going to be the primary drug class. They primarily lower LDL. The big thing that you want to remember is how they work. So they inhibit an enzyme called HMG-CoA reductase, which helps to prevent kind of cholesterol synthesis. The pitfalls is, again, watching out for any evidence of hepatitis or rhabdomyolysis. The other drug is bile acid sequestrants, cholestyramine. Their primary effect is reducing LDL. They work by binding up the bile acids and not allowing them to be absorbed, so therefore you lose a lot of the cholesterol within the actual poop. But unfortunately, if you lose a lot of cholesterol in the poop, it can cause a lot of diarrhea. Same thing as the ezetimibe. It's a cholesterol absorption inhibitor, so it reduces LDL by inhibiting cholesterol absorption, but again, you're going to lose it in the poop, so you can get diarrhea. The next drug is fibrates. These are great for dropping your triglycerides. So the question that also could be asked is, okay, you have a patient who has an elevated LDL and elevated triglyceride. You start them on max dose statin. They're not reaching goal with their triglycerides, but their LDL is in goal. What do? Add on a fibrate. And the way that this one works is that it's supposed to increase the activity of lipoprotein lipase to chew through the triglycerides and break them into free fatty acids. Downside of this one, though, is it is worse with the LFTs and the rhabdo. So if a patient is on both a statin and a fibrate, they're at super high risk for hepatitis or rhabdomyolysis. They can cause gallstones too. Niacin. This one also can drop your triglyceride and for some reason increase HDL. It may work by kind of decreasing lipolysis, but I think one of the biggest questions that come up on the exam for niacin is that it can cause flushing because it causes an increase in prostaglandin pathways, which kind of cause this kind of reactive process. And so treating these patients prior to that with aspirin is going to be one of the ways that they can try to test you for that on the exam. Also watch out for this. If a patient has gout, it can increase hyperuricemia and increase those uric acid crystals, which can worsen gout. The last one is the PCSK9 inhibitors. These are super great drugs and they can drop your LDL like a son of a gun. And they work by basically decreasing the amount of LDL receptors that are endocytosed and broken down. And so if you have more of them present on the cell membrane, you can kind of uptake tons and tons of LDL and drop the LDL really well, but it's just super expensive. So that's one of the pitfalls of this one. All right, my friends, that covers hyperlipidemia. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.